Live, okay, thank you. Okay, good morning everybody. I've got some obligatory preamble to go through before we start, so welcome to today's meeting. I'm Councillor Jason Fazackerley, Cabinet Member for Health, Wellbeing and Social Care. Please be assured that we have the appropriate cleansing and social distancing measures in place to ensure the meeting is undertaken in a COVID secure manner. This has included a request for all attendees to have taken an LFD test within 48 hours of the meeting, the use of the NHS Track and Trace app or attendee log, 2-metre social distancing, the wearing of masks when not seated, and a one-way system into the Guildhall. Limited public seating has been made available, clearly not taken up. This meeting is also being webcast to allow the public to attend remotely if they so wish. Please be advised that the public seating area is not in view of the camera used to webcast this morning. Can I please ask members to remain seated at 2 metres throughout the duration of the meeting and to wear a face covering unless seated. There are no deputations today. Should the fire alarm sound, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assemble at the turning circle at the end of King Henry Street, past the University Park building. In order to comply with the Guildhall Trust fire marshal regulations, anyone who signed in at the Guildhall reception desk should sign out again when leaving the building at the end of today's meetings. May I draw everyone's attention to the fact this meeting will be live streamed. Everyone speaking via a microphone will be on camera, include those making deputations, of which there aren't any. Members of the press and public are also permitted to record the meeting on the understanding that neither disrupts the meeting nor records those stating explicitly they do not wish to be recorded. Please can everyone use the microphones and remember to switch them off when they have finished. That's the preamble out of the way. Any apologies for absence? We all appear to be here, so I haven't got any apologies. Declarations of interest. Councillor Smith.
Yes, my normal one. I'm a paid official of Hampshire Branch Unison, but there's nothing on the agenda that precludes me from the meeting. Thank you.
Okay, no other declarations, so we move to the first formal item on the agenda, which is item 3, informal inspection of regulated services. Andy, you to present. Thank you.
Thank you, Chair. Good morning, all. So the report for you is talking about those services that are run and managed by Portsmouth City Council, providing care and support. The purpose of the paper is to update the portfolio holder as to how adult social care assures the quality of internally provided services, and those services are regulated by the Care Quality Commission. So the number of services directly provided by Portsmouth City Council are registered, set out in detail, along with the process of inspection and the criteria that CQC use to make their assessment as to the quality of those services and then confer a rating upon them. The report also updates on the hybrid approach that CQC currently take to inspection following the first 2 waves of the COVID pandemic. And prior to inspection, it was prior to the pandemic, apologies, it was always a face-to-face inspection, an on-site inspection. But as in common with many other bodies, the Care Quality Commission now does a combination using intelligence that they've gathered, self-reporting data, and then an inspection should they need to face-to-face. The paper then details the overarching quality assurance framework that adult social care uses to audit standards across its care homes, so the work that we do behind the scenes on a regular basis, and that includes an informal inspection process. And the process is supported by colleagues in other areas of the service, including those colleagues from the NHS. The reason that we do that is so that we're not exclusively marking our own homework, if I can use the vernacular, so that we've got other colleagues who have experience of services and can give us feedback and learning. What we then do following those inspections is we link that to a learning process so that we ensure we've got a feedback loop coming in, so that anything that we've picked up or our colleagues have picked up is then fed back to the registered manager, and we put in place an action plan to pick up on that and to correct if it's an error, or improve if it's something that could be improved through a hint or a tip, and also to congratulate staff when we've got a good result from that. Finally, the paper links this process to our governance and assurance process. So informal inspection reports then come to the Senior Management Team Governance Forum, which meets once a month, and we also send those on to the portfolio holder and to the Chief Executive. For principles of good governance, to understand what's going on in our regulated services. That's a summary of the paper, but happy to take any questions.
Colleagues, I brought this report because I thought it would be useful to the newer members, also to myself as being new to the portfolio. As I said before, I think Councillor Smith's the only one amongst us that's got experience in regards to this particular portfolio. So it's useful, I hope, to you to see this, and also for me as well. Are there any questions from anybody? I don't have the little electronic screen here, so just sort of wave at me. Lewis,
just on the informal inspection process, has that, I'm guessing that's changed to a more hybrid approach to kind of match the CQC, and have we found areas of that work that we're likely to keep, or is it likely to revert back as and when we exit out of the pandemic?
What we did during the pandemic was we suspended that inspection process, essentially because the challenge, certainly in the first 6 months or so, was ensuring that we had infection prevention and control together. And while you can do remote monitoring, we prefer to do an on-site visit to see the evidence for ourselves and talk to those people using the service. So we reintroduced them. If memory serves, it was round about April this year, to go back on site. And what we do is, although we didn't have the mandatory vaccination criteria in place then in care homes, we agreed with all of our informal inspectors they'd have a lateral flow test, they'd have been double vaccinated, and they could prove that. So we're back to doing them on site. So we managed partly over the pandemic with informal intelligence, and as you can imagine, we had quite a lot of informal intelligence because care homes were much discussed, including those run by Portsmouth, but we're now back to the full inspection process.
Anybody else? Councillor Smith, Jeanette?
Yeah, in the item 6 about key learning, it says that we learn from incidents and mistakes. How do we do that? Do we do an independent review on every issue that's raised and then learn the mistakes from there, or do we collect them yearly and then learn the mistakes?
So we produce a report, a written report that comes out of this process, and it sort of mimics the CQC process really. We have a certain area that we've looked at and then what we found, what was good about it and what could be improved. And so that report is then shared with the registered manager. The registered manager and the head of service have a discussion in supervision in one-to-one and agree an action plan to implement those, and then that comes back to the senior management team, and that's how we ensure that feedback loop has happened and any actions that were identified have taken place, and then they're signed off, as you'd expect, sort of an Excel spreadsheet type format.
Councillor Mellor?
Thank you. Thank you for your report, Andy. I think the most pressing problem at the moment is the current situation we've got with social care workforce. And my question is, how are we going to manage that, particularly if CQC are reporting negative comments about nursing homes, care homes, etc. We need to be making sure that, the staff are supported throughout this as well, and I just wondered what the situation is with that, please. That was a really jumbled way of saying it, and I'm very sorry.
So we do have workforce challenges within Portsmouth, within our own care homes and within our care homes. They're not quite as severe as the current challenge that we've got in domiciliary care. It doesn't seem that we suffer from quite the same shortages in care staff in care homes. What we try and do in terms of support, the broad thrust of the challenges that we have in social care currently, what we try to do is we use all of the government grants that we get. We do that in consultation with the sector, with domiciliary and breast care, because of course the vast majority of care is provided outside of the council we contract with. We also try and support the care sector with sharing of information. A recent example was as we were coming in the run-up to mandatory vaccination in care homes, we shared the approach that we would take as an employer with all of the care providers in Portsmouth. We shared the communications that we were using with all the care providers in Portsmouth, trying to acknowledge that we have a lot of individual care providers in Portsmouth and they won't have the infrastructure that we necessarily do, although our infrastructure is small, and so we try and share what we're doing, not to oblige them to follow it, but to say if you want to use our materials then please do. So that's a broad support that we do. And we also connect, again, related to mandatory vaccination, we connect with our colleagues in public health and share any materials that they've got, and we have a regular interface with our providers when big things like that are coming up and talk to them about it. In terms of wellbeing for our own staff, we hook into the corporate wellbeing resources that Gareth Spooner administers for us in the council. We also ran a Adult Social Care Wellbeing Week, and I'm going to get this wrong because I'm hopeless with dates, but it was July, August time, where we offered staff the opportunity to log on to certain webinars. We gave them some written material and some links to hints and tips about keeping yourself well and resilient, who to talk to if you're not feeling great, some freely accessible resources, and sort of gathered all that in one place for people. And we're planning to rerun another one of those probably in the spring, I think. We also have a supervision structure within adult social care, so that most people will get a one-to-one with a line manager every month. For some staff, if they're working in ancillary roles, and that wouldn't be appropriate, it'll be every couple of months. But everyone should and does get a level of supervision, so that if something's going on for them, we can pick that up with their line manager, talk to them and offer them the appropriate support. So we tend to do that. We also do annual appraisals for some of our staff. So if they've got targets, if they want to progress in the organisation, if they've got particular training or learning and development needs, then we work with them to identify those and help achieve them throughout the year. And then outside of those more formal structures, any member of staff can approach their line manager at any time. And if they can't approach their line manager, we also, of course, have the whistleblowing policy. If they're seeing something is wrong or putting them under pressure and they don't feel they can talk to their line manager about it. That's a bit of a broad view, but that's roughly staff support stuff. It's a pleasure.
Okay, we've got no more questions. Just say, colleagues, if anybody wants any further detail or information on any of the reports that we have here, or basically anything that comes up through the portfolio, any additional training, any first-hand experience, then by all means approach Andy or any of the officers. I have no problems with anybody getting whatever information they need. So if you do have any difficulties in securing that, which I very much doubt you will have, then by all means come to me and I'll progress it for you. That's the end of that information report. If we move on now to Andy, it's yourself again, Adult Social Care Annual Complaints Report.
Thank you. We run a separate process to the corporate complaints process within adult social care, and you'll find our colleagues in children's social care will also run a specific process because of the nature of the work we do. And so each year we have an annual report. It's been slightly delayed in this calendar year through the impact of the pandemic, so working from home and being able to allocate staff to it. So the purpose of this paper is to update around the analysis of complaints and other contacts that we've received. And the period covered is 1st April last year, last year, to the 31st of March this year. The paper provides an overview of the annual report. It talks about the number of complaints, contacts, and the percentage of those people that use the service that made the complaint. It's quite a low percentage in terms of the people that we provide a service to. That's not always a paid service. That can be information and advice. That can be any contact that we have for that number of folk. The paper then breaks that overview down into some greater detail as to what the complaints are about, the performance on response times for the service, examples of complaints are given, and how the complaints managers administrate the process and support managers to respond appropriately. There's some detail there around the 2 ombudsman cases, and any upheld complaints are also included, as it's information about persistent complainants, as is information about persistent complainants. Whilst in the report councillor and MP inquiries are low, we picked up a need to improve the recording process for that, because we receive far more councillor and MP inquiries than that listed, as you'll be unsurprised to hear. And so what we needed to do was just tie off the recording of that so that we make sure that that's a more accurate report. Finally, the paper highlights the training available to staff and the learning and sort of process feedback loop from complaints. There are a couple of points made in the briefing as well for this paper, the informal briefing before we came to this meeting. So we're looking currently at the number of complaints in our family comparator councils, but we haven't got that information yet, but we'll update on that remotely when we've got that. That was a question from Councillor Fazakerley. We also had a point raised about distinguishing between the majority of complaints in our provider sector, whether that was in terms of what those possessions were that they were about, and in the main it is about laundry. It's fair to say it's been a constant challenge, I think, in all care homes to ensure that laundry possessions go back to the person they come from when you're using a single washing machine, and we try to do that, and we try name tags and all those kind of things, but occasionally that will go wrong. And so we do get some complaints about that, and that was one of the other points you'd asked for clarification on. So there's an example right at the end on page, I think it's page 24 of your pack, 24 of your pack, that talks about that feedback loop, so having a complaint and then doing something about it. And we do similar things with our ombudsman complaints as well. For instance, we've got one excuse me, that we've just had back in draft at the moment, and there's some recommendations, so we'll look to put a small action plan around that, make sure that we can account for the fact that we've read that, learned from it, and taken the actions that have been recommended. And that's a summary of the report, but as always, happy to take any questions.
Thank you, Andy. Sorry. Any questions, anybody? Councillor Smith?
Yeah, thank you. I think first off, what I'd like to say is, although we'd like to receive no complaints, 62 complaints out of 6,687 possibles is a great achievement by the staff, led by Andy, and in a pandemic as well. So you would expect probably those complaints to be a bit higher. So I think, all staff should be really congratulating themselves for getting that service through the last year. The other comment I would like is to make is about the FAB team, and I'm picking up some casework and it's about communication, because general public do not understand the difference between health funding and social care funding, and I'm wondering if that's leading to some of the complaints, and can we do something more with the communication about what the differences are, how people apply, because they seem to be stumbling in the dark, because they usually only hit the service once, maybe twice, but they seem to have a problem with digesting that information, and it's a very confusing picture. So is there anything we can do just to improve that?
I think there's always stuff that we can do to improve communications, I think, because we never get it 100% right, and I think the charging issue is really key. The white paper that was published yesterday, haven't digested it fully yet, around social care, was quoting figures that around 47% of people assume that social care is free at the point of use, as NHS care is in the main. And so that's not surprising. It's also a fact that many people approach and ask for support with social care when they're in crisis or some level of crisis. And so trying to explain to somebody, when you're trying to work with them sympathetically and understand what they need and try and give them some assurance, and then give them a lot of words about charging and all the things that we have to, is a very difficult job to do. And I think in the main, our staff do really well at it. I think there's always stuff we can learn. I'm happy to have a discussion offline about the feedback that you're getting, because any kind of feedback is useful to us. We try to respond when we get a complaint through our FAB team personally, so it's often a phone call followed up by communication rather than more written communication, because people often want to talk it through. And we've done some face-to-face visits as well on occasion when it's been particularly complicated. So try and do that personalised service, which I think in a city as compact as Portsmouth we're able to do. But I think we can always improve. So happy to take some of that feedback, and we'll see what we can do.
Anyone else? Right, okay. Thanks for that, Jeanette. Most useful to have that, and I think I'd echo your comments on, without putting words into other colleagues' mouths, I think we probably all share the same view. That's a really encouraging to see such a low level of complaints compared to, the places that we deal with. So can you pass on, I know there's many staff to pass it on to, but if I just generally publish it through this meeting, then I think we all give our thanks to the staff that have worked in very difficult times. Thank you for that. We now move on to our veteran officer, Mr. Noble, who's been here even longer than I have, I think. So, Alan, across to you for item 5, which is substance misuse treatment and support services retender.
For a minute I thought you had a report on veterans, and I didn't think you'd possibly talk about me. I was only 20 years, so. Good morning, councillors. I've got a report which I've brought just to provide some information on the commissioning plan that we're currently underway to re-procure our substance misuse treatment and support system in Portsmouth. I'm sure you'll be aware that substance misuse contributes considerably to a range of poor outcomes, whether that be health or social, and it affects not only individuals but their families and the wider community. And dependency on drugs and alcohol can have an impact on things like employment, family life, educational attainment, housing opportunities, criminal behaviour, antisocial behaviour. So it touches a very wide aspects within our society. But substance misuse treatment interventions lead to improved outcomes, and they're very evidence-based. And in terms of sort of cost effectiveness, for every £1 you spend, there's usually a return of something between £4 and £8 in terms of other social government services. So substance misuse is linked to a lot of our local strategic priorities, and I've detailed those within the report, and that includes the council's priorities, our health and wellbeing strategy, the community safety plan, and it links to the work of the Office of the Police and Crime Commissioner. So Portsmouth does have a higher than average level of need relating to drugs and alcohol. However, it's not necessarily disproportionate when compared to similar socio-economic areas, so similar cities with similar deprivation. Within the report I've detailed some of the examples of where our need and harm is higher than average. So we have a higher percentage of dependent drinkers, higher rates of alcohol-related mortality, admissions, high rates of mental and behavioural disorders or intentional self-poisoning. And I was asked just to clarify what the intentional self-poisoning is, and it's essentially where someone will deliberately ingest more than a prescribed amount of drugs or illicit drugs which are not meant for human consumption whilst under the influence of alcohol. But it doesn't necessarily say the motive for the individual doing that. In terms of drugs, again, we do have a higher prevalence of opiate and crack cocaine users in the city, so heroin and crack users, and we do have a higher than average rate of drug-related deaths, hospital admissions, etc. So the need within Portsmouth is higher than the England average, but not disproportionate compared to other areas. So in the report I've detailed some of the statistics related to the current service performance provided by our adult treatment service. So that's for people 18 plus. Excuse me. So over the course of a year there were over 1,400 people received treatment. Of those, 411 were new to treatment. We generally find that the turnover of alcohol clients is slightly greater than the drug clients, because traditionally someone who's dependent on heroin will go on to a substitute prescription for a period of time before they then go through for the detox program. And our split in Portsmouth is roughly 2/3 male, 1/3 female, which is broadly similar to the national average, or slightly better. In terms of our re-procurement, in November 16 we initially went out to tender for an integrated service, which was the drug and alcohol treatment service and the supported housing service. and we're maintaining that going forward. Our current provider in the city is the Society of St James as a lead provider, with Solent NHS as a provider of the medical services on a subcontractor arrangement. And I've sort of detailed the services which are included in the specification, and it ranges from harm reduction provision, which is the saving lives, trying to reduce the spread of bloodborne viruses and overdoses, through to detox, and then enabling people to maintain their sobriety or their clean status after they've had their treatment. So it's the range of medical interventions, whether they be pharmacological or psychological, from the point at which someone engages until the point at which they feel they no longer need any support. So that contract has run for just over 5 years now, and we're at a point where we have to re-tender. So as part of our planning and preparation work for the re-tender, we undertook consultation work, and we had a total of 207 responses, and roughly 65% of those that declared their status were service users, which is a really good response rate for service users. But we also had responses from carers and other professionals in other related sectors, so for example mental health and probation. And we got a number of feedback, showed a number of areas where we could suggested improvement. They're detailed within the report, but an example would be enhanced access for people, some out of hours provision, supporting people on long-term substitute prescribing to move to the point where they become substance free, and then increased work around what used to be called dual diagnosis, but we now call co-occurring substance misuse and mental health issues, and women-specific services. We have so oversight of the project has very senior kind of clinical support. We've had a public health consultant, we've got the assistant director of adult social care, a clinical lead from the clinical commissioning group, and a representative from the Police and Crime Commissioner's Office, and they form our steering group that is overseeing the commissioning process. I've detailed the timetable in the report. Our aim is that we will start the new service on the 1st of June 2022, and actually the tender submissions are due next Friday. The report details some of the priorities which we are focusing our tender on, and so for the substance misuse treatment service we're focusing on women offenders, alcohol-only service users, parents, grandparents and carers of the addicted person, people with complex needs, and that includes co-occurring mental health conditions, and veterans. But my only reference to veterans in that report. We're also looking at expanding within our housing provision the offer of clean and dry housing, so where there is an expectation that people will not use drugs or consume alcohol at all. In terms of the funding, the total budget for this, for the substance misuse treatment service, coming from public health funds from within the City Council, is just under 2.6 million, but that does include some contributions from partners, for example the Police and Crime Commissioner's Office and the Clinical Commissioning Group. And then there's an additional 330,000 which is from Adult Social Care, which funds the support to the supported housing element. So it is a slight increase on the funding this commissioning round compared to last commissioning round of around 270,000. We also have a peer-led service which we're commissioning separately, and that provides independent peer-led support for service users from the point of access again to the point at which they no longer need treatment but they need activities and engagement and support, and peer-led services are very good at doing that. But they'll also provide advocacy and mentoring from peer to peer, which has got a very good evidence base. So finally, the contract length. We're looking at initial contract of 3 years and 10 months. However, we are building in the ability to extend for an additional up to 6 years, but only in increments of 1 to 3 years. So the potential maximum length of the contract will be 9 years and 10 months. And this, having longer contracts is actually following guidance which has been published recently. There's a report called the Dame Carol Black Review for Government, where she made a recommendation about offering longer contracts to provide greater stability for a longer period for providers. I think that's it.
Thank you, Alan. Very detailed. Colleagues, any comments, any questions? Councillor Mellor.
Thank you for that report. Certainly in Charles Dickens, we get a lot of residents complaining around the fact that people are using in the streets, often using stairwells to inject drugs and then leaving drug paraphernalia lying about, which is a concern obviously for the residents that live there. I just wondered if there's any kind of drive in trying to improve that situation and places where people can dispose of needles safely. And also, I forgot what I was going to say now, so I'm really nervous today and I don't know why, my apologies. So basically it's just about the needle stick injuries, and then obviously you say about the clean and dry houses, so what's the process of getting people off the streets from using and into those clean and dry houses, please? Thank you.
In terms of the needles, there's certainly probably more we could do around that. I mean, there's definitely more that we could do in terms of providing needle bins in more public places if premises are willing to have them. So, for example, we've certainly put additional needle bins, and we've funded needle bins in the Central Library because they were having the issue. So we're more than happy in any premises where there's an issue, if you let me know, I can speak to whoever the landlord is, if you like, and we can see what they will allow, and certainly we could look at providing some secure needle bins. There'll be metal ones fixed to the wall, not plastic ones. All the pharmacies that provide needle exchange are supposed to take returns. So what I will do following this meeting is make sure that I send a reminder to them to make sure that they ask for returns as part of their service distributing needles, just to provide a reminder to that. In terms of the housing pathway, the substance misuse pathway works very, very closely with the homelessness pathway. So as people are engaged within the homelessness pathway, an option for them is to move on into the substance misuse pathway. And the pathway itself has a range of housing from high support through to lower support. And it should replicate someone's treatment journey. So the higher support buildings, you will expect a greater level of chaos, greater levels of challenge, and still some substance use. But as they engage in their treatment journey and engage through the supported housing pathway, they should move on into other premises where the tolerance for substance use is less. And in terms of clean and dry housing, that will be at the end of that pathway. So if someone goes through for a detox, for example, comes out, they will go into clean and dry housing with an expectation that they don't use. So the two should work in parallel and complement each other. To some extent, where we struggle is if someone relapses or has a lapse, do we evict them and chuck them out on the street? Because it makes that situation a lot worse for somebody. So it's trying to manage those tensions of looking after the individual, but not losing not having an impact on the other residents that are living there who are trying to maintain their sobriety. So it is always a challenge and a tension, but we don't want to make people homeless. So if we can avoid that, we'll try and do that.
Okay, don't be nervous, Kirsty. I hope it's not me. I try to be gentle. Any other questions or points, anybody? Okay, well, thank you, Alan, for that. We now move on to our final item, which is the COVID intelligence update. Another near veteran officer. Actually, can we do a power? Oh yeah, you can actually today. Won't be a surprise, colleagues. Obviously, this changes on a daily or weekly basis, and I think with the emergence of yet another variant, it's no surprise that we're seeing rises yet again. Particularly worrying, I think, is the death figures, which I think you sent me this morning. So I'll pass over to you, Matt.
Thank you, Chair. I was trying to work out the last time I was in this chamber, and I reckon it was 2006 or 7, presenting a community strategy to council, a very long time ago, but nice to be back. So yeah, as the report says, there's a weekly update on the council website that has the latest data on COVID for Portsmouth that's updated every Friday. For this briefing, I'll bring you slides that have more up-to-date data, but then the publicly available data will be updated again tomorrow based on a range of data published during the course of today. So, as Councillor Fazackerley stated, cases have been going up recently. So this chart shows the 7-day rolling average of daily new cases in Portsmouth. So on average over the last 7 days, we've had 176 new cases, over 1,000 in the last 7 days, and just under 34,000 residents have tested positive at least once during the course of the pandemic. As you can see there, it's been increasing over the last couple of weeks. Generally, it's been fluctuating, but within a reasonably stable range, more or less since the easing of restrictions in June, July last year. So hopefully we will see this current spike start to come down, but at the moment we're seeing increasing cases. A mixed picture across the four Hampshire and Isle of Wight authorities. So this shows the 7-day rates of infection by upper tier local authority of Hampshire and Isle of Wight. And you can see Portsmouth on the top right, increasing slightly. Southampton also has been coming down a bit, but started to level off that decrease, and Hampshire and Isle of Wight both seeing steady increases over the last couple of weeks. And it's a similar picture nationally as well. So the map shows the rates per 100,000 by upper tier local authority, with darker red areas being the higher rates and pale blue the lightest rates. You can see there Portsmouth's 7-day rate is at 521 per 100,000, up 7% on where we were a week ago. We're above the England rate but below the South East rates. The highest rates in the country at the moment are Devon and Surrey, so there's a large swathe along the south coast, but also high rates in a number of parts of the country. And those overall rates are high and have been consistently high for some time. We look at our data in more detail using our local data. So this is the same 7-day rate per 100,000 for Portsmouth, but broken down into broad age bands. Again, showing over the whole course of the pandemic, so you can see how different waves have happened in different ages and at different times. The pale blue line, the 0 to 14s, has very much been driving the increase in cases throughout the autumn term, but we have seen high and increasing rates in adults, in 30 to 44 and 45 to 59-year-olds, more or less kind of mirroring those rates in children, and they've all been increasing over the last few weeks. We've also seen, as you can see in the sort of dark blue there, for the first time really in this autumn wave, a sharp increase in the younger adults. So it's 15 to 29-year-olds. There are rates in that, so that will pick up some of the older secondary age pupils, but also we are seeing increased rates in 25 to 29-year-olds as well. The positive within that is the over 60s rate. The red line remains reasonably low and stable, so those older ages that are at most risk of hospitalisation and severe outcomes from COVID remain relatively low. The next chart breaks that same data down just for the period from September and looking specifically at younger people. So we've got on the top there, on the blue line, the 5 to 11-year-olds, so roughly corresponding to primary school ages. The yellow line is secondary ages, the red line covers college and university, and then the grey line is the whole adult population, and the pale blue line is preschool. So you can see there that since there was a large decrease around about the half-term period, so a combination of some reduction in testing in those secondary ages, but also reduced mixing as well. Since then it's been reasonably stable in secondary ages, but we have seen increases in primary ages, potentially showing some impact from the 12 to 15 vaccination programme on those secondary rates, but they are creeping up over the last few days. And those rates do remain very, very high in both age groups, just below 1,000 for secondary and just above 1,000 per 100,000 for primary ages. Apologies for the rather text-heavy slide here. Obviously, the recent emergence of the Omicron variant, you'll all have seen, I'm sure, lots of coverage in the news. I just tried to grab some of the information about it, so that I've got it as a reference point, really. But don't worry too much about covering everything that's on there. The text at the bottom just summarises what we know at the moment about the Omicron variant, and I won't rehash this in too much detail because I'm sure you're all following the news. But the mutations in it make it a concern, which is why it's been sequenced and become a variant of concern so quickly. Obviously increasing rapidly in parts of South Africa. But the main thing is that we're still very unclear the precise correlation between the Omicron variant and any increasing epidemiological situation in the country, and likewise in the kind of emergence of cases in other places. So there's a lot we still don't know in terms of transmissibility, severity, and risk of immune escape. So it's still a kind of emerging picture, and we don't know enough to make confident predictions at the moment. There's a very technical issue around a particular type of test, one of the PCR assays for it, that picks up what's called S-gene target failure in the Omicron variant, as it did with the Alpha variant. And it's the reverse S-gene positive Delta variant, which allows us to get a good handle on how it's spreading within the population at a kind of public health level. But so we will be able to understand as it becomes the dominant variant if it does compared to Delta, but we don't know at the moment. And on the top right there is just the definitions around what counts as a confirmed case. So confirmed case means it's been genetically sequenced, and I believe we've had 32 confirmed cases in the UK now. That was what I saw last night. Probable cases are any that travelled from those countries that are considered a risk and have tested positive. So there is a lot more probable cases. I don't know the precise numbers, but a figure of around about 8,000, I believe, people flew into the UK from those countries in the period from the 1st of November through to the announcement about the red list. So all of those will be considered probable cases if they've tested positive. Not all of them will have tested positive, but any that have since will be considered probable. So there's a lot more probables than confirmed, and then possibles are any that come out SGTF, so S-gene target failure positive, again from the 1st of November. So we do know that we will get more cases. There are cases identified now. There will be more. We don't know enough yet to say beyond that what any of that means, but I think you can see from the level of national and international response that there is at least significant concern about the potential risk. Next slide covers vaccinations. So on the right hand side is the publicly available information about vaccine uptake in Portsmouth that we normally cover in these, and that will be covered in the updates that's published tomorrow. We're at 78% first dose and 71% second dose in Portsmouth. That's all those aged over 12. And the total numbers are down below that. The map shows vaccine coverage by lower super output areas, so these are small neighbourhoods of around about 1,500 people, and this is based on just adults aged 18 plus, and it's second doses up to the 11th of November. The piece of work that we did in support of our NHS colleagues that are leading the vaccination programme. And you can see in the darker areas the areas that have got lower uptake, and the lighter areas the areas of higher uptake. So you can see that the lower uptake of vaccination is very much concentrated in the southwest portion of the city, and generally corresponds to areas of deprivation, and has done historically, but also to areas with a different demographic profile. So areas with a younger population will have lower uptake because less of the population will have been eligible for the vaccine at each of the stages as it's been rolled out as well. And there's a degree of caution in interpreting all of this data because it's only as good as the data that is in the national system around where people are registered. So you'll see a very dark area that roughly corresponds to Gunwharf Quays that we believe is more an issue around second homeowners in Gunwharf Quays not being registered in the right place and it not picking them up properly, rather than there being a particular issue with uptake there. However, it gives a good, I think, overview of where the challenges lie in terms of vaccine uptake. The next slide is the latest published data, which should be updated today on the national website around hospitalisations. This is all of the Portsmouth Hospitals University Trust catchment, not just Portsmouth residents. And along the bottom, you can see the daily number of new admissions or inpatient diagnoses with COVID-19. At the top, the total number of patients in hospital with a confirmed diagnosis is currently at 67. You can see there that in this latter wave, the impact of the vaccination programme in significantly reducing that link between increasing infections and increasing hospitalisations, but there are still a significant number of COVID admissions at the hospital, alongside all the other pressures that are always present but growing as we move into winter. So a challenging picture there, and as Councillor Fazackerley said at the start, whilst COVID mortality has been low throughout this wave, we have had a small increase over the last few days. There have been 10 deaths within 28 days of a positive COVID test in the last 7 days, bringing our total since the start of the pandemic in Portsmouth to 405 COVID deaths. We're still awaiting further information on those, but looking at the published data that covers up to the around about the third week of November, all of the deaths that we'd seen in Portsmouth over the previous 3 weeks were all in hospital. So these are predominantly patients who are very unwell and unfortunately die, and who have had a positive COVID test, not necessarily patients that are dying specifically as a result of their COVID infection. And my last slide covers total deaths in Portsmouth each week. So again, we try and do this to understand how COVID is impacting on overall mortality. The grey bars along the bottom represent the most each week of deaths in Portsmouth. The right-hand side is the most recent week. And then the green diamonds that you can just about see are the average number of deaths in Portsmouth in that week over the previous 5 years. So to give you a comparative pre-COVID, 2015 to 2019. So if it's above the diamond, we call that excess deaths or excess mortality, and below it means we've had fewer deaths. Broadly speaking, at the moment, we're seeing around about the same number of deaths as we'd normally see in a typical week at this time of year. And I will stop there, Chair. Happy to take any questions, as always.
Thank you, Matt. Colleagues, any questions? Councillor Gosley.
What's been put in place with regards to helping the residents in the north of the city? So obviously they've now got no testing sites. Are the team still doing the outreach work with the lateral flow kits to get to the north of the city?
I will get a fuller answer for you from Helen, the Director of Public Health, but certainly lateral flow tests are available to all residents from pharmacies, which are available in all localities, so they can access the tests in that way. As you know, the testing facilities have reduced in the city, but hopefully by keeping the one in the old Sainsbury's car park in the centre of town, it provides the best possible access to the large number of people that we can.
Councillor Miller.
Thank you. At the moment, obviously, because of the rising cases, places of education are really, really struggling, as are our GPs and QA hospital. So I was just wondering if you'd be able to let us know what provisions are in place locally at the moment to support schools and QA with the increase of cases, please.
I may defer to Andy to talk about the support that's available to QA, but certainly in terms of schools, we do have regular contact with schools, regular meetings with them to go through the support that's available, and we liaise with them and with the education team who are in daily contact with those schools to provide all the support we can with advice, but also access to the national support that's available to them.
Thanks, Matt. In terms of QA, there's a combination of things really, because whilst Matt's report was relating specifically to COVID, as we know, the increase in vaccinations has given us a very different picture in terms of hospitalisation for COVID at the moment. It's still a pressure. I think Matt was talking about 60 folk in QA with COVID. We did go up to 90 at one stage this week, but then that fell again, and any extra pressure on the NHS in winter is very difficult. We're also seeing real pressures around staffing in the NHS. They've been hit in the same way as many other sectors in health and care have been, particularly in acute hospitals. And we're also seeing pressure in terms of being able to take people off ambulances into the emergency department. So we're seeing queuing ambulances up at QA. So the support is quite wide and varied, really. At normal times, you'd expect very regular conversations between all of the NHS trusts in the locality and the local authorities. So for QA, there's 2/3 of the patients roughly will come from living in Hampshire and 1/3 will come from living in Portsmouth. So that's why Hampshire County Council is involved as well. And the two health trusts, Solent and Southern Health, also support in that hospital footprint along with the relevant CCGs. So there'll be very regular interface. There are many daily huddles, I think, and discussions and meetings talking about the number of people that are being discharged, where they're going, where the pressure is in hospital bed occupancy, and how the discharges need to increase. What we're seeing slightly differently this winter is a greater focus on prevention of unnecessary admission. And so putting in place resources, excuse me, at the front door in the emergency department, clinicians that can take a view on whether someone needs to wait in the emergency department to have some treatment, whether they can be diverted elsewhere for the relevant treatment, or whether they need to be admitted. Depressurising the main emergency department so that if we think treatment or support can be offered in that same day in QA, excuse me, that can be done, and then someone can return home. But also going further upstream in the jargon and looking at the calls to the ambulance service to SCAS. So having some of our community staff, shared community staff, NHS and local authority, looking at the calls that are coming into SCAS and whether there's alternatives that mean that SCAS don't have to be called at all, and therefore that lowers the chance of admission. Another initiative, just thinking of some examples, is within our care homes in Portsmouth. We have something called telehealth. So for our care homes that will agree to it, we've got a 24/7 connection to a medical clinician. So that, for instance, a nurse or a carer in a care home, if they're worried about one of the residents, rather than having to out-of-hours default to call the ambulance, for example, or the out-of-hours GP, they can call this number, they can get a clinician, they can use the video technology to show the injury if it's an injury, or to show the person and how they're responding. And then we can, by doing that, we can lower calls to the ambulance service and thereby admissions. To emphasise that anyone that does need to be admitted will be admitted, but it's just trying to work with people in their own environments when we don't have to move to admission. There's also facility in the community at the moment for clinical assessment service managed through the CCG, so that anyone who might be at risk of going to hospital from their own homes, there can be contact made for a medical review, a clinical review, so we can prevent admission in that way as well. So I think the pressures are intense and immense. It's not just locally, it's up and down the country, but I think we're seeing a focus both at the back door of the hospital, those people that need to be discharged and where they need to go to, but more importantly this winter at the front door of the hospital as well. So if we don't need to bring someone through that hospital process, we don't. It's much better for the individual and much easier for services involved if we can ensure that the right care, be that medical or social care, can be offered in someone's home than it is if they've gone up to the hospital, they've waited on an ambulance, they've gone through the ED, they've then been admitted and they then need to be discharged. So that prevention priority is really key, I think. I hope that gives you a broad sort of sweep.
No, that's the point. I mean, I had a meeting yesterday with several of the senior NHS members as we obviously we're moving towards the end of the CCG next year and the creation of the new integrated care setup, and things that Andy's just touched on, which you've mentioned. I mean, there's a whole range of issues affecting us: dentistry, obviously ambulance delays, COVID pressures, backlog of operations, retention and retaining of recruitment of carers. That was an initial meeting that was only for about an hour, I think, yesterday, but we agreed to set some more up and I'll extend the invite to yourselves to come in and sit in on those. I think it's important for us to know what it's going to look like when it comes into effect next April. So I'll make sure when the next, we haven't actually arranged a date yet, but when we do, I'll make sure you're all invited to it and sit in on it. So again, useful to know. So if there's no further questions on that point, colleague, that's the end of the agenda today. Can I just thank you for attending? Thank you for everyone that contributed, and that's basically it. You can all go away. Thank you. Bye-bye.